I've lectured briefly for an interview one time. I don't know how well I did, so I apologize if I do really poorly today. If I'm not talking loud enough, or if I'm talking too fast, just tell me, because I tend to do both. And I like handouts better, and then just pictures on a PowerPoint. I hated PowerPoints with notes on the side, so that's why I'm doing it like this. So the first thing we'll talk about is acne, rosacea, folliculitis, which are kind of all in the same vein. So is this up? Yeah. So this is the pathogenesis of acne, which is what I'll talk about first. And there's typically 4 main reasons that we get acne. The first thing that you will see in the slide is where it says number 1 is follicular plugging. So it starts as a microcomedone, which then forms a comedone, which a microcomedone is like a small blackhead, and a comedone is like a blackhead. So you have to start with the core being dirty. And so that's what a microcomedone is. So then a comedone will form when corneocytes accumulate in the hair follicle, leading to hyperkeratosis. So basically it gets plugged up. So that's what that number 1 picture is right there. I think that's what that is. Yeah, okay. The second thing is excess sebum or oil, and you can see that in that little circle picture where it says increased sebum production next to the hair follicle, which every hair follicle in your body has a oil gland attached to it. So it's typically caused by androgens, like when you go through puberty, namely DHT and DHEAS, which are types of testosterone. So that's typically why males, yes?
Do we have a PowerPoint for this?
Yes.
You have a PowerPoint for this?
Yeah, it's under, it says acne and rosacea,
Yeah, we
JD.
hit load more.
Yeah, I can't find it either. It's under
Do
clinics.
some of you have it?
It's quite the very bottom.
Yeah.
Load more, hit load more at the very bottom.
Did you get it?
Yeah.
Okay, good. The third thing is the presence and activity of P. acnes, which is a type of bacteria. It's typically deep in the sebaceous follicle. Sebaceous is another term for oil. It proliferates inside a pustule, causing more inflammation. So you can get a pustule in a hair follicle. And a pustule is just a pus-filled hair follicle. So if there's any activation of the bacteria P. acnes, that can proliferate the acne. And the last thing is the inflammation. So once the hyperkeratotic hair follicle, hyperkeratotic meaning there's a lot of keratin, either from the comedone or sloughing of dead skin, it then expands and fractures, leading to a pustule, and it becomes inflamed. Then it becomes nodules, cysts, and it gets worse and worse, and then it can lead to scarring. The other thing that they don't really mention a lot is genetics. Most of the time when people have acne, there's a familial component. So mom or dad had acne, aunts and uncles, grandparents, they had acne. So yes, it's due to all 4 of those in this picture, but genetics plays a big role too. So going down to clinical features, typically what you see with acne are a combination of lesions, including comedones, papules and pustules, nodules, and cysts. So this is an example of open comedones or blackheads. Not a lot of inflammation, some inflammation, but mostly blackheads. Closed comedones are blackheads. My bad. Open comedones are whiteheads. Does that make sense? Okay. The next slide shows mainly papules and pustules. So this is the more inflammatory type acne. And we'll get into the difference of treatment of non-inflammatory acne like comedones and inflammatory acne. The next one is nodules, cysts, scarring. So this is a really great picture because she had basically what we call acne conglobata. And it's rare, but it can happen. And so that was on the left, that was before treatment with Accutane, and then that's her on the right after Accutane, which we'll talk about too. So does anybody have questions about what the lesions look like? Okay. So then we'll get into treatment. That's really all the pictures I have of acne. It's pretty self-explanatory, isn't it? We know what it looks like. So treatment's kind of broken down into topical treatments, oral antibiotics, oral retinoids, and hormonal therapy. And every patient's going to be a little bit different. That's why history is really important. Talking about timing, how long they've had it, what kind of acne they typically have, what they've tried. So the first type of topical are topical antibiotics, and those mainly work against that bacteria I talked about, that P. acnes bacteria. A lot of them are anti-inflammatory, but they can't get rid of the comedone. So if they have a lot of comedonal acne, topical antibiotics really aren't going to treat this type of acne. There's a ton out there, and there's so many different brand names, and you have drug reps come and tell you about why their product is superior. It just matters after you've used it a lot. So everybody's different how they respond to it, but these include topical erythromycin, clindamycin, sulfur, benzoyl peroxide, and dapsone. And there's a brand name for all of those, and some of them are in combination with one another to work a little bit better. Some of them are combined with topical retin-A too, to kind of skip a step. These are typically used either once or twice a day. Bacterial resistance typically happens with topical erythromycin, so we don't really use that one very much anymore. If you add benzoyl peroxide, it lessens that resistance, and then it gives the comedolatic properties, meaning if you had a topical clindamycin with benzoyl peroxide, that can help with the comedones. So that's a nice combination. But basically, those are the types of topical antibiotics we use for more mild inflammatory acne. Topical retinoids are the comedolytic topicals. And so those are the ones that are going to be active against blackheads and whiteheads. They're also anti-inflammatory, and they're typically used at night. They can cause sun sensitivity, and that's typically why we use it at night. So we will instruct the patient to wash their face the next day and put on sunscreen. They will be more sun sensitive. The names of topical retinoids would be tretinoin, adapalene, and tazarotene, and there's brand names for all of these as well. And they're used alone or in combination with the topical antibiotic too. So that's more. Topicals are reserved more for kind of mild acne patients that haven't really been on a lot yet. And sometimes we use it in combination with the systemic medications too. Which brings us to oral antibiotics. And it's basically treating the P. acnes colonization of the skin and follicles, and it also decreases inflammation. Most of the oral antibiotics that we use are doxycycline and minocycline. Although I know Amy and I have used Bactrim and azithromycin too, it's more second line. But the doxycycline, minocycline family works really well in hair follicle issues, which includes acne, and we'll talk about it later, folliculitis. So it's more of a narrow spectrum antibiotic. It's more anti-inflammatory than it is antibacterial. Most of the side effects that you'll see would be GI upset. So I tell people to take it with food. Sometimes it can decrease its absorption. That's why there's a lot of different oral antibiotics now that are created in an extended release way to where it won't cause a lot of upset stomach. It increases the absorption. It can cause photosensitivity, especially in doxycycline. So sometimes in the summer, I won't prescribe doxycycline as much just because of the sun sensitization. You can see vertigo or dizziness and hyperpigmentation, mainly with minocycline. It's more of a blue discoloration I have seen in a couple patients around the gums and even in the scars where they've had acne too. I've only seen one or two patients. It's really rare, but I do mention it as a potential side effect. Also, Stevens-Johnson and TENS can occur in sulfin. I've seen that one time, but it's still something you warn against, so it's not a good one. The third treatment option are oral retinoids, and this is when we're talking about Accutane. Accutane's generic name is isotretinoin. There's a lot of different names now for Accutane. There's several generics available and newer brand names. And basically the way I describe that, it works different than oral antibiotics because it doesn't necessarily help with inflammation or infection. It works by normalizing epidermal differentiation, and it suppresses sebum production and decreases inflammation by doing that. So it works more on the oil gland around the hair follicle, so kind of a precursor to any inflammation. It's a great drug. I've probably prescribed it to thousands of people. It's a little bit tedious because you have to enroll in a national system called iPledge, and that's in order to keep it available to patients. And they provide contraception counseling because it's a teratogen. When they came out with this medication in the 80s, and it was, kind of a miracle drug and cured most people of acne, there was a lot of different side effects that were reported, and one of them was if you were pregnant while on it, you had a baby with birth defects, like hydrocephalus and that sort of thing. So they've termed it a Category X medication. Another thing, you have to do blood work, and everybody's different how they do their blood work. I like to do it every month. There's a lot of studies that show you don't have to do it every month because there's not much change. But we watch their liver function tests, and the reason we do that is because it's filtered through your liver just like Tylenol is. And so if you took Tylenol every day for 4 to 5 months, which is typically how long you take Accutane, we want to make sure your liver was healthy enough and functioned well enough to filter it. So we watch liver function tests. We watch lipids because it's a fat-soluble vitamin A, and since it's fat-soluble, it has the potential to raise your cholesterol, mainly triglycerides. So I have had some patients have to get off of it because their triglycerides were too high. I've treated some of their triglycerides, but most of them just get off of it. We also watch a CBC mainly for neutropenia. I haven't seen that happen very often, but it is known to happen. For any females of childbearing potential, this includes any female with a uterus. I don't care if her ovaries are gone. I don't care if her husband has a vasectomy. If she has a uterus, she can get pregnant. So any female that's of childbearing potential, we get an HCG. Whether you get a serum or a urine, it doesn't matter. I typically just get serum since I'm getting blood work anyway. I typically see patients every month and monitor their blood work because of these types of side effects that we've seen. The most common side effect is dryness, and again, this is because it's decreasing the activity of the oil gland around the hair follicle. So not only will your skin be dry, your hair, your nails, your lips, your eyes, your joints can be dry. So everybody's dry. They're not, that's weird. They're not taking it right. So I have had some people have headaches, and I think that's mainly because they don't eat with it. So I always say to eat with it. You can get an upset stomach if you don't eat with it as well. We also don't like for them to take Accutane in combination with a doxycycline or minocycline because it can cause pseudotumor cerebri. Upset stomach we talked about. Blurry vision, mainly you see it because their eyes are dry or if they're contact wearers. Arthralgias occur because your joints get dry, even your synovial fluid can kind of dry up. So as long as they're okay with that, it's fine. Sometimes if it's really bad, I'll tell them to take Aleve or ibuprofen, just not Tylenol, and you don't want to take the two together. And I have a lot of patients that get really freaked out about Accutane because, you get online and you really go down a rabbit hole about it causes depression. And I take that serious, but there's been absolutely no studies that can link the two. There's not a causal relationship. So I don't really listen to those kind of concerns very well. Nothing evidence-based, we'll say that. I do ask if they've had a history of moodiness, depression, anxiety, suicidal ideation, that sort of thing, and I ask them every month if they feel like that. Typically we giggle and move on, but I do take it really serious if they do talk about it. And something kind of interesting I just read about is most studies have shown that isotretinoin can improve their mood or have no negative effects on mood, memory, attention, or executive functions. But again, I monitor this throughout the entirety of their therapy. And there's also, the latest thing is it causing inflammatory bowel disease like Crohn's disease, ulcerative colitis. They still can't find a causal link. I do ask about that history because Accutane can kind of be a stressor on the system because of what a high-risk medicine it is. So if it's in their family lineage to have Crohn's or ulcerative colitis, I guess you could say that sometimes it can stress the system enough that it can bring it out earlier, although they're probably going to get it at some point in time anyway. But I've had nobody have problems with that. I've even had 2 patients that have a history with Crohn's be on it and have no flares at all. So again, no causal relationship. So I don't really let people get too freaked out about it. Most people get freaked out if they're putting their teenage daughter on it. because then they think, oh, I'll get on birth control and that gives me the right to do whatever, which is something I've tried to tell them is not true. They don't listen to me very much. The last type of treatment is hormonal therapy. The one that I use the most is a medication called spironolactone. And the way that it works is it binds to the androgen receptors, thereby reducing androgen production, which thereby suppresses sebum production. You only use it in females, of course, because since it blocks androgens, you don't want to do that to a male. I don't like it if females are on it while they're pregnant, though, because if they're pregnant with a male fetus, that can decreases androgen production. I do monitor blood pressure because it is a hypotensive, and I also watch potassium levels because it's kind of one of those ones that's sticky for potassium. A lot of times people are on spironolactone if they're also on Lasix, and that's because Lasix is such a diuretic, you can become hypokalemic, and this kind of helps you hang on to it. Some people will say, oh, I think my blood pressure lowered when I'm on it. I have the world's lowest blood pressure and I'm on spironolactone. It has not lowered my blood pressure because we use it at such low doses for acne that you just don't get that hypertensive effect. I do monitor it just because I have to, but I don't think it matters. The other type of hormonal therapy are oral contraceptives for women, and it's typically adjunct. I don't necessarily see a patient and go, oh, you need to be on birth control. You know, typically if I think it's more hormonal, I'll put them on spironolactone. I have had some younger teenage girls with irregular periods, cramps, that sort of stuff. Get on it, and it helps with that, and it'll help with their acne. It also reduces androgens and increases sex hormone binding globulin, which decreases free testosterone. The one that they really typically used to prescribe was Yaz because it had drospirenone in it, which is kind of like spironolactone. But you have to monitor a lot of side effects. You know, if you're on birth control, you have to have uterine exams and pap smears and all kinds of stuff to monitor for irregularity. So I don't typically prescribe it. If they ask me if they should be on it, I say, you know what, that's great. If you want to go to your OB-GYN, they put you on it, that's fine. It may or may not work. So I don't know many derms that typically prescribe it more than they do spironolactone. So that's all of treatment for acne. Does anybody have any questions? I said that really fast. About any of the treatments or any of the words I used? Okay, we'll move on to rosacea. Rosacea is typically an acne look-alike, and it's mostly in fair-skinned individuals. I've been told that it's mostly in German descent individuals, and it typically peaks in the 3rd or 4th decade, and males are most commonly affected. It's related to vascular hypersensitivity. There is kind of an effect by food, alcohol, temperature, sometimes neurology, like if people get really mad, that's sometimes when their rosacea will flare, or if they're crying or that sort of thing. It can be an inflammatory reaction also to Demodex mites. They reside in the lumen of sebaceous follicles in the center of the face. So just like everybody has yeast on their skin, staph on their skin, we also have these little tiny mites that live in our pores on our face, which is weird. And sometimes it can just be a reaction to that. So the reason I say that is there are some treatments now that are geared towards those mites. Other triggers can be sun, alcohol again, physical exertion, stress, and spicy foods. I don't know. I don't know if I believe that or not because I've asked people that, and sometimes it's not even a factor. But that's what's been written about. So clinical features, there's several subtypes, but most patients exhibit central erythema, flushing, telangiectasias, which I have a picture of, those little vessels that are dilated, those are telangiectasias. Also red papules, pustules, and nodules. And the big thing about rosacea is there's no comedones. So if somebody comes in and they look like they have acne and you don't see comedones, you can probably label it as rosacea if there's a lot of central characteristics of their acne. Also rhinophyma, sebaceous hyperplasia, and possibly injected conjunctiva. You'll see sometimes people come in and they have really bad rosacea and their eyes are really red. So this slide is mild, inflammatory rosacea. Here's more of the papules and pustules, and see how that's more on our central face. You don't see a lot around the jawline, but it's around the nose and central cheeks. And then this is rhinophyma. So that's a lot of sebaceous hyperplasia activity. And it's typically in men. I've only seen like maybe 1 or 2 females with this. So that's clinically what they'll present with. There's also a common variant of rosacea called perioral or periocular dermatitis, and it consists of small pink papules and pustules that recur over weeks, and it's typically exacerbated once they've stopped steroids. So they don't typically come to you at first with this. They'll feel this rash kind of coming on around their nose, which this is a really bad case. They'll feel like a rash around their nose or around their mouth, and they'll say, oh, that's itchy. So they'll go get some topical over-the-counter cortisone, and they'll start putting it on there, and it'll look better after a few days. But as soon as they stop using it, it just comes back with a vengeance, and then that's when they come to your office. So history is really important with this one. It's typically tingly. I've
Can I add
noticed.
something to that?
Yeah,
Kind of an
absolutely.
interesting case. I had a woman who had a very persistent case of perioral dermatitis, and finally dug down and found that she used a steroid inhaler for her asthma, and just the small particles of that landing on her skin, or we put two and two together eventually, and found that that was what was driving that. So just that aerosolized steroid, how we kind of treated that was we said, either kind of cover your face with a napkin or washcloth or something while you're doing that, or put a thin coat of, say, not Aquaphor because that's going to clog your pores, but CeraVe ointment while you're doing that, and then wash that off afterwards.
Yeah, I've seen that too. I've seen it in babies too, when they just have a lot of maceration around their face from drooling. They'll get kind of that perioral dermatitis. But I think it's because parents will start using topical steroid.
I also think that you're not going to read this in a book anywhere, but just from experience, I think it's kind of hormonal driven or something, because the two most common groups I would see the perioral dermatitis in was a kind of a pre-teenager, male or female, and a kind of a perimenopausal woman.
Yeah, absolutely. I agree. And there's symptoms to it. It's tingly, it's itchy.
Yeah.
But it's hard to get rid of. And, people kind of freak out when you say it's kind of a rosacea and acne mix, but you can get rid of it. It just takes a while. You kind of treat it the same way you would acne. So then we'll go into treatment. So again, topical and oral treatment. Topical treatment for rosacea includes metronidazole, azelaic acid, sulfur, pimecrolimus, which is Elidel, tacrolimus, which is protopic, it's present in ivermectin. Typically avoid steroids. I worked with one dermatologist, and they used it all the time, and I'm like, they're just going to get worse. So what I like to use typically with perioral dermatitis is the pimecrolimus, which is Elidel. I'll use that in the morning, and then maybe like a rosacea topical like metronidazole or the azelaic acid. Sometimes I'll even use like clindamycin you would use for acne. Sometimes they have to be on oral antibiotics too when they have perioral dermatitis. But for true rosacea, we'll use a lot of topical metronidazole, azelaic acid. The topical ivermectin, the new one, is called Soolantra, and I've had some people respond really well. That's the one that would kind of target those Demodex mites. Response varies, but that's typically the topical treatment. Oral treatment, again, includes doxycycline, minocycline. Some people do oral metronidazole, except it causes a lot of side effects, and it's typically not tolerated GI-wise. Bactrim and isotretinoin. I've never had to put on anybody on isotretinoin for rosacea. Have you? I don't think I ever have. They do really well with doxy, and there's a lot of different kinds. The tetracycline family works by decreasing the chemotactic response of neutrophils. It inhibits granuloma formation and inhibits protein kinase C. That's all in the inflammatory cascade. That's why it works so well for rosacea, because it's very inflammatory. Surgical treatments are typically used for vascular rosacea. So if they have that flushing all the time and they have that telangiectasia like we saw on the first slide, and it's persistent, you can do the pulse dye laser. I actually had that done. I was a lifeguard when I was younger, and I got tons of sun damage, and so I always had a persistent redness centrally. So I did the little pulse dye laser. It takes a couple treatments, but it works really good. For the rhinophyma, like we showed, gentleman with the big nose, sometimes people will do loop cautery or CO2 laser to get rid of it, but it's really hard to treat. So that's surgical treatments. Not a lot of people do that or have to do that. The last one in this group is folliculitis, and it's kind of all-inclusive of acne and rosacea too, because it's just hair follicle inflammation. So it's inflammation and infection of the hair follicle, usually caused by staph, but occasionally Pseudomonas. Pseudomonas causes what we call hot tub folliculitis. The damaged follicle caused by irritation. Irritation can include when your clothes rub on your skin, trauma to the skin, shaving, sweat blockage. You'll see sometimes people will get it around their rear end in the summertime because of sweat and occlusion. Also oil and makeup will occlude those pores. Growth of stiff hairs into the skin, like around a man's beard, can cause chronic low-grade irritation or inflammation that can mimic infectious folliculitis. We call it pseudofolliculitis barbae. So typically you see this in the beard area. Clinical features, the most common locations are the face, chest, back, arms, legs, buttocks, and head, which is really everything. I don't know why it gives the specific places. Anywhere you have hair, you can get folliculitis. Typically, signs are a superficial pustule surrounding a hair follicle with itching and burning. So sometimes people will come in and they'll complain of a rash, and a doctor will go, oh, well, it's itching, you know, here's a steroid. Well, that's going to make it worse. And you can see that it's folliculitis. It's little pinpoints, and you can see it's around the hair follicle. So you give them a topical antibiotic, and they clear up like that. So that's a lot of times what we'll see coming over from primary care. They've been using an antifungal. If that doesn't work, they use topical steroid, and then you save the day because you give them a topical antibiotic because it's folliculitis. You can also use different types of acne washes too for this kind of thing. That brings us into treatment. So sometimes it's just avoiding shaving the area if you can tell for sure it's from shaving. Changing the razor often, warm compresses, antibacterial soap, and a non-occlusive moisturizer. So for example, if I ever get anybody, especially my men that come in and they've just got really bad beard folliculitis, or if I get women that have a really bad bikini line folliculitis, I tell them to go get a big bag of those thick razors that are like $1 a piece with a single blade. Because now we use 17 blade razors, and that's just going over the hair follicle 17 times, and that's just going to irritate the hair follicle. So if you get a big bag of those razors, use a different one every time, use a good shaving cream that's not perfumed and that sort of thing, and maybe not shaving as often. That definitely does help. Warm compresses, sometimes if it turns into like a furuncle or a carbuncle. And then the antibacterial soap, I typically have them use like a benzoyl peroxide soap, and that works beautifully. Friction and rubbing must be avoided. That's really hard when you have a guy come in that works construction and he wears jeans and he's got terrible folliculitis and that's all he can wear. But maybe he can just loosen them up a little bit. Lycra, workout clothes, and tight-fitting rough fabrics like jeans. Again, that's sometimes really hard. Areas of chronic folliculitis are typically areas of shaving, waxing, hair plucking, or friction. Typically treatment with clindamycin lotion or gel or foam. Again, there's 100 different vehicles you can put clindamycin in. It just kind of depends on where it is. So if it's the armpits, if they get really bad axillary folliculitis, you might want to use something like a foam that's not too moist. You can use a lotion maybe on the face if they have dry skin. So kind of think about the vehicle you're giving them. Typically twice a day for about 7 to 10 days. You may have to treat it longer. I've had people have to do it for 30 days if it's been there a while. Again, benzoyl peroxide 5% wash, love it. It's over the counter, cheap. Sometimes if it's really bad and they have like some warmth, erythema, any edema, I'll put them on Keflex or Cephalexin, sorry. Dosage of about 250 to 500 milligrams TID to QID for 10 days. You can use dicloxacillin. I never do. I just think there's too much of a resistance to it. Doxycycline is kind of my go-to if it's been there a while and it's kind of smoldering under the surface. I'll use 100 milligrams twice a day, or minocycline. And sometimes I've had to put them on it for 3 months. That's about how long it takes for it to actually get into the system, get around the hair follicles, and cause the inflammation to go away. Hot tub folliculitis, that's when you'll see it, they have history of being in their hot tub every night, and they've got it around their swimsuit area because of occlusion and being in the hot tub. It'll go away on its own, you just have to avoid the hot tub for a while. Another really interesting one, I know you've seen this before, Amy, is pittosporum folliculitis. Somebody will come in and they'll be complaining of acne, and it'll be on their back, and it'll be a man, and they sweat a lot. And you look at their back and they've got, papules and pustules. The difference between that and typical acne of the back or the chest is all of the bumps are the same size. In acne, you've got an evolution of lesions. You've got comedones, you've got nodules, cysts, papules, you've got all of it. It's not just same size papules, same size pustules. So that's what pittosporum folliculitis looks like clinically. I should have brought a picture and I didn't. And it's typically because of warm weather, occlusion, or excessive sebum production. You treat this different because pittosporum is a type of yeast, so you're not going to give them topical antibiotics since that's not going to do anything. And sometimes that will clue you in that that's what it is. You'll put them on topical antibiotics for 3 months and they look just the same. So I'll give them topical antifungals, iconazole, fluconazole, kind of whatever you have. Sometimes I'll put them on systemic fluconazole, which is diflucan, and I'll do 100 to 200 milligrams a day for about 3 weeks. Sometimes you can pulse dose it and do it 1 day a week for like 6, 7 weeks, and that gets rid of it, and they're happy as a clam. So, does anybody have any questions? I said that really fast too. We're ready for fungus.